So Dr. Fisher has a PhD in epidemiology from the University of Ottawa and is currently a postdoctoral fellow at the Dalla Lana School of Public Health at U of T, and with Public Health Ontario, funded by a CIHR Health Systems Impact Fellowship in Equitable Artificial Intelligence. And I think she's going to talk to us a little bit about those fellowships as well. She is also a postgraduate affiliate with the Vector Institute for Artificial Intelligence in Toronto. Her postdoctoral work is focused on evaluating the use of population health prediction models for informing public health activities and supporting Public Health Ontario in building capacity for artificial intelligence. So welcome to our group, Stacey, and I'll ask you to unmute and go ahead.
Awesome, thank you. Thanks for that introduction. Thanks for having me. Yeah, like just kind of building off that background a little bit, I thought I'd give you just like a little bit more about my background and how I got to where I am doing AI ML for public health in the public health context. So, I have no computer science background. I did my undergrad in biology. I have an MSc and a PhD, both in epidemiology. My MSc was mostly in health services research. In my PhD, I changed my focus to population health and developing prediction algorithms designed specifically for informing population health planning. So as part of my PhD thesis, I developed a prediction algorithm for dementia using just traditional public health, traditional statistical methods. And it's now being incorporated into the Statistics Canada microsimulation model to be used to inform population health dementia planning at the national level. But both my PhD supervisor, Dr. Doug Manuel in Ottawa, and my current postdoc supervisor at the University of Toronto, Dr. Laura Rizzella, they were both starting to collaborate with AI ML researchers during my PhD. And they kind of really began to recognize that there was a lot of potential for these kind of AI methods to improve population and public health. So as I started to kind of become exposed to more of that work, I really started to feel that potential as well. I did a couple, intro to machine learning workshops, online courses, that kind of stuff. And then, given my training in population health predictive modeling using traditional methods, I not only began to see the ways that artificial intelligence and machine learning can improve public health, but also how public health and epidemiology can perhaps help improve the way that machine learning is done and some of those different methods. Now, at the same time, CIHR was really starting to recognize this potential for those, these kind of methods to improve public health. And so I believe it was around 2017, the Institute for Population and Public Health launched a bunch of different initiatives focusing on artificial intelligence and public health. And so one of these was to earmark a bunch of money from the new Health System Impact Fellowships, specifically for fellows who wanted to use AI methods to address public health challenges at some specific health system organizations. And so that's where this Health System Impact Fellowship in Equitable Artificial Intelligence that I was awarded in 2019. So that's kind of a little bit about like how I got to where I am. And as it was mentioned, I was asked to briefly go over the Health System Impact Fellowship in case any of you guys were interested in applying. And so I'll go over that now. It's a fellowship for trainee programs at both the PhD and at the postdoc level in public health, economics, health policy, informatics, a bunch of different related fields. And the overall goal was to support impact-oriented career paths and elevate career readiness of individuals with a PhD in health services and policy research and related fields by supporting experiential learning opportunities outside of the traditional academic environment, really focusing on enriched competency development that is important for working in those kind of fields and bringing together this national cohort of current and past Health System Impact Fellows. And so these are kind of the enriched core competencies they talk about. In our traditional training, we get a lot of, the ones in the red, the research and analytics skills. You learn how to do analysis, interpret your data, present your data in manuscripts, that kind of stuff. But you lack a lot of that professional skill development. And if you're not planning on staying in academia, especially, a lot of these professional skills are really important. And so this fellowship really focuses on these other skills. I've been doing a lot of, this change management and implementation in my fellowship that I had, no experience with previously. So yeah, this fellowship is pretty different from your traditional CIHR doctoral or postdoc awards. You're embedded within a health system organization. So I'm with Public Health Ontario, and I'm being supervised by the acting CEO. And you're really supposed to be working on projects that are of interest specifically to these organizations. So I'm working to increase AI ML capacity for Public Health Ontario and the public health units in Ontario by helping to develop new organizational informatics strategies and inform the development of an artificial intelligence strategy, among some different things. And so I kind of looked at on the website, if you Google health system HSIF host partner linkage tool, you can see all the different organizations that are actively or we're actively looking for students to work with. And I just kind of looked at places that were in BC, and there's a whole range from the BC CDC, BC Cancer, Northern Health Authority, Lung Association, Work Wellness Institute. There's a whole different list there. And you're supposed to spend, at least 60% of your time embedded within the organization. And then you can do, say academic work on the side. So I'm developing a new version of my dementia risk tool using machine learning methods with my academic supervisor as part of the other part of it. How much money do you get? So $45,000 for PhDs for 1 year with a $5,000 research allowance, or $70,000 a year for 2 years with a $7,500 a year professional development allowance. And this isn't just AI work. You can do any sort of health system impact work. There's the general competition, which has the most number of spots, the most money for it. I was awarded through the equitable AI competition because of that, priority within CIHR that I talked about. But there's a lot of opportunity outside as well. And really what I really love about it is there's lots of networking and mentorship opportunities, not just with, these health system and academic leaders, but also just with each other. There's the current cohort, and then you have the previous cohort. And I mean, it's now all virtual, but we're really getting to know each other. And once a year, they try and get us together. Back last November, 2019, we all got together in Toronto for a couple days, and it was really great. So there's just lots of different training opportunities that I've been able to do through that. So that was just kind of my general introduction to this award. Now let's kind of move on to what I came here to talk about. I just wanted to give some general introduction to artificial intelligence and machine learning, talk about some of the opportunities and challenges associated with AI/ML in the context of public health, occupational health, environmental health, and look at some specific examples, lead poisoning and foodborne illness. So the creation and availability of novel health data has really increased dramatically over the last 20 years. So it's really providing detailed insight into different lifestyle, environmental health risks that have really never been possible before. So here we have a figure of the 4 V's of big data. So volume, this data is really big. Velocity, it's often streaming in real time. Variety, there's different forms of data, whether it's structured, unstructured, for example. And veracity, there's a lot of uncertainty, there's missingness, it's messy. So, data from social media, web search engines, news media, mobile devices can all provide this information about social determinants of health that's a lot more nuanced than from our more traditional sources. Wearable devices collect information about personal movements and physiological measurements. Environmental sensors collect spatial data about air pollution, water quality, environmental noise, and linkage of these novel data sources to our more traditional public health data can really expand the potential use of this. And so artificial intelligence and machine learning are tools that we can use to help really take advantage of this data for improving population health. So let's start with a quick poll question. I just want to get an idea about what the audience knows about AI ML. Is there much experience? Have you had any training? Have you done it before? Or are you pretty new to it?
Okay, the poll is launched. We usually wait till we have sort of 75%, 80% completeness. Got a lot of folks interested in this topic today, which is wonderful.
Awesome. Yeah, this is kind of, I guess, I don't know if anyone can see it yet. This is
Not
kind of what I
yet, not
expect.
until I close
Yep.
it and share it, but we've still got answers coming in pretty fast, so I'll give it a couple more seconds. There, I think we're good. So I'm going to
Awesome.
share the results. Now everybody can see them.
Great. So yeah, a lot of people pretty much nothing. That's like good to know as I kind of go through this. I think kind of listening to this presentation will kind of bring you up into that next little level there. It's also always interesting to see that there's always a couple people. I always find this, in every group, there's always a couple people that have that experience. And it's kind of nice to know that, there are other people in your department or something that you can go to if you want to kind of explore this a little more. So this is great. Awesome. All right, next slide. So, okay, what is artificial intelligence? So it's a science of making machines do things that would require intelligence if they were done by people. And it's really an umbrella term that includes machine learning, which is a lot of the time what we kind of refer to, what we are talking about a lot of the time. It also includes natural language processing, which is another big one that is pretty common within public health. But it also includes things like deep learning, which is a big hip word right now, image processing, and robotics. So it's a lot broader than what we tend to focus on in public health. Okay, so what's machine learning? So it's a branch of computer science which enables computers to learn without being directly programmed, a technique that fits models algorithmically to patterns in data. And so a lot of the time, there is some discussion of, are some of our traditional statistical techniques considered machine learning? There's kind of a fuzzy line. People have their different definitions, but by this definition, it does seem to be that there is some overlap. Another definition I wanted to go over quickly is precision public health. So as I was talking about, there's this increase in the type, size, complexity of health-related data, and it's really providing us with these new opportunities. And so just like big data and genomics, for example, with AI have led to the advent of precision medicine, AI also has the potential to really facilitate improved targeting of population health interventions and policy to populations that are most in need, known as precision public health. So AI can be used to inform how we target the right intervention to the right population at the right time. There's other purposes for AI that we'll get into as well. But I think that's one of kind of like the biggest things that's been talking about a lot is precision public health. Now, another thing I want to emphasize is machine learning is just another tool, and it can be used to tackle problems for which our classical methods are not well suited, usually having to do with this big data. But it's not, a hammer for every nail. It's not well suited for addressing all questions, but it is another tool that you can have in your toolbox in order to help answer the questions that you're interested in. Now, one of the stumbling blocks in starting to understand machine learning is often the lingo. But fortunately, a lot of the different terms do have analogs in epidemiology. And so there's there's a citation here at the bottom, What is Machine Learning? A Primer for the Epidemiologist, a paper from AJE in 2019. And this is a good one. There's also, there's quite a few papers like this out there. And reading a couple of these papers can actually get you pretty far in getting a better understanding of machine learning. Just getting kind of some of these basic definitions can really help you when you're listening to a talk or reading a paper. When I was at my first machine learning conference a long time ago, me and my supervisor were just getting into it too. And we were sitting there beside each other being like, when they say features, I think they mean like the variables in the model. And when they say labels, I think they mean outcomes. And we're sitting there trying to like keep this in our mind as we're listening. And so even just like those basic things, you can kind of like tie it back and you'll realize that a lot of what they're doing is very similar to what we're taught. They just have different words for it. So, another one that I remember coming across was like one-hot encoding. It's creation of dummy variables, like it's a little different than that, but it's just kind of interesting to go through and realize that they have a lot of these same terms. And it makes it a lot easier to, again, go back and forth between what your training has been in. Now, this is another one of the main general concepts that's really good to come away with from the beginning. is that there's, your two main types of learning. So there's supervised learning and unsupervised learning. So supervised learning is like your traditional regression that, we're taught in epidemiology classes. So your goal is to produce a model that accurately maps your inputs to your outputs, your variables to your outcomes. And so you're using labeled data. You have the outcome in your data set. Classification refers to models where the outcome is categorical. Regression refers to models where the outcome is continuous. Not the way that we typically think of the word regression, but again, it's when you become familiar with some of this stuff, it becomes easier to understand. Unsupervised learning, there is no outcome. So one example that I think some of you would be familiar with is principal component analysis. That will be a type of unsupervised learning. You don't have an outcome, but your model is working on its own to discover information using patterns in the data. So clustering involves finding natural groups within the data, and association involves finding relationships between data variables, which can be used to, for example, suggest what you should buy after you add something to your Amazon cart. They're using unsupervised association learning. There's also semi-supervised learning, in which both supervised and unsupervised methods are used in stages. So by having this kind of general understanding first of what supervised versus unsupervised learning is, then it's easier to kind of get into these different types of machine learning. You hear about k-means, you hear about neural network support vector machines. It all just seems like a lot much. But when you kind of break it up, it becomes a lot easier to understand what these things are doing when you want to get into more of these specific concepts. So this is another good paper talking about big data, machine learning, and public health, going through some terminology and different examples of, some of these specific methods and how they've been applied to different public health questions. So that's another good one to maybe take a look at. Okay, so I've kind of went over like some basic overview of AI, ML, and there's some really good papers out there that kind of can give you that general baseline understanding that can really get you pretty far. I'm going to move on now to talking about some opportunities and challenges through the research that I've been doing so far, the literature reviews that I've been doing. So there's lots of different opportunities for AI to improve public health, occupational health, environmental health. AI can be used to more quickly identify emerging threats. So for example, Blue Dot, a Toronto AI company, was the first to detect and report on the outbreak cluster in Wuhan that became COVID-19. So that was using AI. AI can also be used to provide more detailed and up-to-date understanding of population disease and risk factor distributions. So population health surveillance is a really big thing. So there's a lot of different approaches for health surveillance that can provide event estimates that are more up-to-date than our traditional methods, as the data are often collected, processed, analyzed, all in real time, which allows us to have more of a up-to-date understanding. Public health surveillance dashboards have also been developed to display different health events geographically and over time, and again, up to date. And they often use these untraditional data sources like news reports and social media data combined with information from traditional sources that again can provide us more detailed and up-to-date data. AI can also be used to predict future disease incidents or even future risk factor incidents. So as part of my fellowship, I'm developing a prediction model for dementia. And again, it's forecasting what's going to happen in the future in order for us to help inform how to plan for this. And there's been many examples of how the machine learning method can improve, can work better than your traditional methods, especially if you're taking advantage of the kind of data that AI is well suited for. Better targeting of health promotion activities. So there's an increasing number of AI-powered interactive online tools or applications that provide individualized risk assessment, risk reduction recommendations. And there's more opportunities for, in population health management, evaluating the effects of policy change, even causal inference, and even like helping with the production of systematic reviews of public health interventions, using natural language processing to go through different papers and pull out the important information to perform a systematic review. So, question for you, thinking specifically for occupational environmental health, what do you think is, some of the biggest opportunities for artificial intelligence and ML to improve this? So I have some of my different suggestions there, and if you have any other ideas, I'd love to see them in the chat box. What you guys think?
Yes, we realized we couldn't solicit free text responses to this in the poll itself, but if you have other ideas, certainly the chat box is a good place for them.
Awesome. Yeah, no, this is looking good. Lots of similar things to what I'm finding in public health more general.
I haven't seen any comments in the chat box pop up yet. Oh, Mike Brower says use of imagery to estimate exposures, environmental exposures, I'm guessing in this case.
Yeah, for sure.
All right, I'm going to end this and share the results.
Awesome, thanks. So yeah, identification of emerging threats and risks. I think that's definitely a big one that's interesting. Again, I don't think a lot specifically from the occupational environmental health perspective. So I was really curious what you guys were thinking. And if anyone wants to expand on what they mean by, specific threats or risks, I'd be interested to hear what you had to say, or we can chat about it at the end. But no, that's great. Thanks for participating. All right, I'll move on to the next one. So challenges. And then after this, I'm going to ask you what you think the biggest challenges are as well. So if you want to start thinking about that. So there's, lots of different challenges, risks, limitations to using AI for health, for public health. And a lot of people, this is like a really big hot topic right now that a lot of people are focusing on and spending a lot of time on. So one of the big things is explainability. So decreased interpretability. Machine learning models tend to be a lot less interpretable than, being able to interpret a beta coefficient from a regression, for example. A lot of different, privacy concerns, potential for increased inequities and bias, as well as, there's just kind of a general lack of workforce training in public health in these areas in AI. So it's really hard for us to take on some of these challenges. In addition, there's also just structural challenges like data sharing and insufficient infrastructure to actually perform these kind of techniques. There are, however, I think, solutions to a lot of these different challenges. And this is kind of some of the stuff that I'm focusing on in my postdoc work, is how we can prepare Public Health Ontario. A lot of it is the infrastructure, the training, data sharing in order to be able to do these things. But one thing I think is really interesting is that in public health, we think about bias all the time. We think about equity all the time. It's ingrained in us to think about these things. And in computer science, it's not. And so I think it kind of mitigates some of those challenges that we've been trained to think about this. So I think there's a lot of what public health can bring to computer science and AI is how we think about these things and the ways that we can, even just simply evaluating for bias when you're done a model. Oftentimes this isn't done. So I think there's a lot that we can bring to AI ML that can help with some of these general challenges. So what do you guys think is the biggest challenge to using AI ML for occupational environmental health?
I am going to launch this and then go deal with some barking dogs.
Sounds great. So there was a little bit of a jump up in the beginning with privacy concerns. That's definitely a big one. I think being able to access data is one of the biggest things. I work with the Vector Institute in Toronto, and there's so many times where they've been brought in on a project and they're excited to get to work on it, and they're waiting a year to get access to the data, or sometimes that they just never get access. I think it's definitely an issue.
There's also some stuff popping up in the chat. I don't get to vote because I'm a co-host, but mine would be related to training and integrated training in public health and computer science and machine learning and all of these things. We've got Hayang saying graphic processing, I guess, GPUs. Trainees sometimes get intimidated by the math and the programming if they don't feel confident with those skill sets to begin with. Access to reliable public data sets in modern formats. I would also say access to reliable training data sets for trainees. A lot of the times we want to work with data that do have those privacy concerns, and there aren't good analog training data available. So lots of thoughts.
Awesome. Yeah, so as I was saying, privacy concerns, data access and sharing, big issue. I do see this stuff getting better. It is really difficult in health, but people are working on it. Things are moving forward much slower than we would hope, but yeah, there's definitely a lot of different challenges to work on here. All right, thanks. So I just want to go through now a couple different specific examples. So let's start with this one, validation of a machine learning model to predict childhood lead poisoning. So this paper was published in JAMA Network Open in 2020. So a little bit of background, childhood lead exposure can cause vomiting, convulsions, paralysis, and even death in high concentrations. And chronic exposure can cause irreversible neurobehavioral deficits, acute toxicity, and lower IQ. So therefore, lead poisoning is really associated with significant indirect societal costs, an estimated $200 billion in the US alone. Now in Chicago, an estimated 80% of homes were built prior to the banning of lead paint in 1978. And so it's therefore recommended that every child in Chicago be tested for elevated blood lead levels at age 1, 2, and 3. So here's a page from Public Health in Chicago. Now, if a child is found to have elevated levels of lead in their blood, Chicago Department of Public Health will perform an inspection of the child's home and look for potential sources. But since the effects of lead are not reversible, a primary prevention approach would be much more preferable, rather than only inspecting homes after a child has been exposed. However, it's been estimated that it would take the Chicago Department of Health 75 years to inspect all at-risk homes in Chicago, given their current resources. So it would be advantageous to have a way to prioritize homes for inspection by identifying children at the highest risk of lead poisoning. So what they did is they developed a model. They used data from 1997 to 2012. So that's on almost 200,000 individuals. And they used temporal validation to validate the model on data from 2013 on 6,000 people. So they have lots of data here. They have spatial and spatial temporal data. So building information, as well as data about blood test results from 2.5 million results, home inspection records of 70,000 homes, permits and violations, as well as sociodemographic variables at the census tract level, education, health insurance, home ownership information. So here's just kind of a big display from their supplementary tables. They've got spatial temporal specified at over 11 different spatial levels and time periods. Their spatial predictors in table 2 are specified at over 5 different spatial levels, and their area level sociodemographic predictors are in table 3. So basically they end up with like 1,000 different predictors, and they use it to train a random forest model to predict elevated blood lead levels. And then they also ran a simple logistic regression model, which included many fewer variables. So just these variables I have here, and then they use fixed effects for 77 different Chicago neighborhoods. So random forests are a modeling methods in which many different decision trees are developed, and they're used to together produce an estimate. So at the simple level, we can think about decision trees. It's a supervised learning method, and you can actually visualize them as flowcharts, as you can see there on the right. They can be used to predict either continuous outcomes or categorical outcomes. And what's really great about them is that they're highly interpretable. they more closely approximate human decision making compared to other machine learning methods. That's one of the big advantages about them. They found that the random forest model performed better than the logistic regression model. So they looked at C-stats, 0.69 compared to 0.64. And they looked at their sensitivity, specificity, positive predicted values across different populations at risk. And again, the model consistently performed better, the random forest model compared to the logistic model. One thing that was really great about this paper is they also investigated how the model performed by ethnicity to investigate potential fairness concerns. So they found that the incidence of high blood lead levels was higher among non-Hispanic, Black, and Hispanic participants. And that the model itself, the random forest model, performed differently across ethnicity. So there was greater sensitivity, lower specificity for non-Hispanic Black participants, which also may be associated with the higher incidence in that population. And they did talk about this in their discussion, and they suggest that you could use different risk thresholds by ethnicity if you do want equal performance across different groups. So they did provide some recommendations about how the model could be used to have equal performance. So I thought this was a really great paper. I really like that they evaluated across different ethnic groups. The Chicago Department of Public Health does plan to use this model to prioritize home-led inspections. They said that if they proactively inspect homes from their validation cohort, all of them with the top 5% highest risk scores, they could potentially prevent lead exposure in up to 16.2% of expected cases. So, that's not too bad. That's a good start. And that's actually twice as many prevented cases than if they would have used the logistic regression model. So in this specific example, it does seem like machine learning did perform a lot better. They were able to use those, 1,000 variables and able to create a model that works pretty well for this purpose. There's also potential that, they talk about publishing the risk scores to inform prospective home buyers, motivate people to get lead inspections and perform remediation if it's needed. They talk about, potentially including these risk scores in children's medical records and teaming up with health and social service providers to facilitate inspections for patients that are at high risk. And there's also potential to outreach and perform education programs with landlords. So yeah, that's kind of what I wanted to go through with that first paper, just kind of a good example. Here's another example that we'll go through: machine learned epidemiology, real-time detection of foodborne illness at scale. So restaurant inspections are mandated by public health standards in both Canada and the States. And in general, these inspections are really expensive, especially considering the really large number of restaurants that all receive usually at least one inspection per year. And there really is not that much evidence regarding the utility of this current inspection frequency. So this study is a collaboration between researchers at the Harvard School of Public Health and with Google. They developed the Foodborne Illness Detector in Real Time, or FINDER, which uses machine learning to detect in real time foodborne illness using anonymous and aggregated web search and location data. So for this, they use so there's two main sources of data. They use the web search data and they use location data. So the web search data is when you go on Google and you search for a term. They use natural language processing as well as a bunch of different web pages about foodborne illness to develop a model, which was used to identify if a web search query is about foodborne illness, where every query is given a score between 0 and 1. And when they compared this model to experts, it performed really well with a C-statistic of 0.85. So for example, here, diarrhea probably has a pretty high score, close to 1. Whereas if you're searching for something else completely unrelated, it would have a score closer to 0. So secondly, they use anonymized location data. So ambient location data is collected by Google when you opt into location services on your mobile device. So they use this data to identify the restaurants visited in the 3 days prior to a web search about foodborne illness, as well as to evaluate the total denominator. So how many total people who are opted into location services visited this restaurant. And then they use the Finder model to produce a list of restaurants to inspect. So yes, they have their web search data to estimate the probability that they have the symptoms. They use the location data to estimate the proportion of visits to a restaurant that were followed by a web search query related to foodborne illness, which produces a list of restaurants. And then the model is then, the model was deployed in 2 local public health departments. So in Chicago and Las Vegas from May to August 2016. It's also worth mentioning that the last study, the lead inspection study, was also performed in Chicago. They really are big leaders in the application of AI to local public health. So the Finder model identified 132 high-risk restaurants for inspection. In the same time period, over 10,000 baseline inspections were performed. In Chicago, where 5,800 baseline inspections were performed, most were routine annual inspections, whereas 1,300 were driven by complaints. We also see we have a breakdown of the inspections by risk level, and we see that on average, the Finder identified inspections were higher risk. I should also mention that the inspectors were blinded to whether or not the inspection was identified by Finder or whether it was routine or complaint driven, which influences, hopefully we don't have much bias in the risk level. Okay, so does the Finder model actually identify more unsafe restaurants than the more traditional approach? So yes, restaurants identified by the Finder algorithm had over 3 times the odds of being unsafe than baseline inspections. And it was even better at finding unsafe restaurants than complaint-driven inspections, 1.7 times the odds of being unsafe compared to complaint-driven inspections. So this model could conceivably lead to more efficient restaurant inspection and more precise identification of illness outbreaks. However, there was only 132 restaurants that were identified by Finder, so that is a very small sample size. And also, as I'm sure a lot of you are thinking as I'm going through this, there's a lot of privacy concerns related to the use of location and web search data. And so this really needs to be carefully considered. You know, I talked in the beginning about all these different sources of data. You know, you've got like your Apple Watch recording your physiological measurements. You know, like these things are being collected, but to what extent do we want to be using all of this different information? Do we want to be, working with Google to get this kind of information? Or is there, maybe better ways that we can do similar things? There is, that's definitely one of the biggest issues is where is the data coming from? Do we want to be using this data? Thinking about privacy concerns for sure. Okay, so that's pretty much all I've got, leaving us quite a bit of time here for some discussion. Just to wrap things up, I've got a couple different learning opportunities and resources I think I'll just point out. Here's the Artificial Intelligence for Public Health Summer Institute. It was supposed to start this past summer, but it was postponed to 2021. So you may want to keep an eye out for that if you're interested in learning more about AI and public health. One thing I also want to mention is that, again, I'm not a computer scientist. I didn't go back and retrain in computer science. A lot of this is about collaboration. You get your basics, you get your general understanding, and then you learn from each other. And there's not just you learning from the computer scientist, but they can learn from you as well. So I think, you develop that general understanding and you collaborate. You don't have to go back to school in order to do some of this stuff. Collaboration really is key. Here are some, general learning resources. There was quite a few papers I pointed out throughout that are really good places to start. I really like the Coursera machine learning course from Stanford. That's more of a kind of an in-depth course, but I think it provides a really good foundation if you are interested in getting a little bit more training. Social media research training toolkit's really good if you're interested in using social media data. And a couple different sources there. But thank you for listening. I'm happy to discuss and take questions.